So just give it a couple more minutes. We definitely want to get started soon and get y'all back to work on time. Oh, and Chad is in the waiting room. So our first speaker is here. I'm going to give it just 2 more minutes and we'll get started. Put the agenda up for your perusal. Good morning, Chad. Do you have any? Do you have slides you're going to want to screen share?
I actually don't have any slides. I was just going to talk off the cuff, make it easy.
Sounds good. We'll just be transfixed by your dulcet tones. Okay.
And LJ doesn't have the link either. I'm going to forward your email to her, Kevin, if that's okay.
Okay, sounds
we weren't
good.
invited to the Cool Kids Festival.
Okay, it's 8:04. I think we should get started. Folks will keep coming in. So Kevin, Kelly, if you'll keep checking on that waiting room and letting people in, I appreciate your help. Good morning, everyone. Thank you so much for giving up your time today to come and check in with AHP. We've got some updates for you and hopefully lots of time for questions or any concerns that you want to share. But the agenda that we have planned, at least for today, is up on screen. And if anyone can't see anything or hear anything, please throw it into the chat and Kevin or I will help you with any technical problems maybe that you're experiencing. But otherwise, let's get started. We're going to start with some welcome and introductions. Chad Teeters, our Executive Medical Director, is going to talk about 2020 measure performance improvement. Willie N, one of our colleagues in our IT department. I'm so sorry, Willie. You think after all this time I would be able to pronounce your name more easily, but I can tell you I spell it really quickly now. But Willie is here anyway to speak to the recent Arcadia upgrade and walk you through some of the new screens that you're going to be seeing through the user interface when you log into Arcadia. I'm going to give an update on 2019 gain sharing, and which many of the primary care practices that are on the call should have already received their checks. I want to talk about clinical integration payments and how it relates to the APPs in primary care offices, so your primary care nurse practitioners and physician assistants. Erica Dobson, our manager of pharmacy services, is going to speak briefly about pharmacy site visits in support of her 2020 pharmacy initiatives. And then I want to talk about information blocking and the 21st Century Cures Act, some legislation that's impacting some operations at the medical center and will impact private practices as well. So before I turn it over to Chad for the 2020 measure performance, I do want to welcome some folks who I know are new to our group. Nicole Stratton, maybe not totally new. She's been with Alexander Medical Group some time, but she is now their official practice manager at Alexander Medical Group. So welcome, Nicole. And Holly Norson joins us as the new practice manager at Irondequoit Pediatrics. So welcome to Nicole and Holly. If there's anyone I missed, please throw yourself into the chat and I'll make sure that I acknowledge you later in the call. But that's it for welcoming our new attendees. So I will turn it over to Chad to speak to 2020 measure performance improvement.
Thank you very much, Renee. Welcome, everybody. Thanks for joining us this morning. So no surprise to anyone here, 2020 has not been a normal year for quality metric performance. And one of the reasons that we haven't been beating everyone over the head with this for the last year is because we've all been a little bit indisposed in other venues for the last few months. So we are recognizing that we have maintained an eye on our overall quality metric performance. And I will say in many, if not most cases, despite the pandemic, we've actually still done relatively well in many venues. So I think, everyone deserves kind of a round of applause just for being able to keep our head above water in an area where it wasn't our primary focus, especially as patients weren't coming into the office. Despite that, clearly there are some areas where we have slid in our performance, and that is not a surprise. There are some of those areas that are just not realistic that we will be able to improve upon this year. And as a, for example of that, if you take something like well child to 15 months, where they need, 5+ visits, you can't go back and recreate the wheel and have 5 visits in the remaining 4 months of the year. So we realize that some of these are going to be unattainable, and that's okay for the purposes of this year. But what we have tried to do is focus our attention on the places where we think that there is importance to overall patient health, and also potentially importance to the response to the pandemic itself. So, I think all of us can agree that most of these quality metrics are just good, sound primary care. So there's none of them that any of us would say, oh, don't worry about that, it doesn't matter. But there's also, we realize that there's only a certain amount of bandwidth that everyone has at this moment, and that we need to focus our attention where it can best be spent. And I will say this has been an ongoing process within the AHP leadership team. Elizabeth Sharp heading up the optimization team, Willie and Christy from the IT side following our performance, and then Renee, who heads up our performance and our PR clinical team, to really kind of look at and synthesize where do we think we have the most options. And then LJ and George and I just kind of get together and follow everybody's lead and do what they tell us. So that's been the success of where we're at right now. I will tell you, and it's on the screen, so the Arcadia upgrade. So you are now able to see your performance within Arcadia. So you will be able to see where you stand as a practice, which will be useful. But you're going to see a lot of red, and you're going to see a lot of metrics where we are underperforming, and we realize that it's going to be important to try to work towards all of this and just provide good care to our patients, but also we need to focus our attention. So what we have decided for the rest of this year is to focus our attention really in 3 key domains. So one, the diabetic measures, which is diabetic nephropathy, diabetic retinopathy, and hemoglobin A1C less than 8. We already provided some chase list efforts back to you earlier on in the pandemic as we were looking to reach out to those diabetics and hypertensives who were uncontrolled. So hopefully that has already helped fuel some of your identification of patients who may need to be moved to the top of the list and seen before the end of the year anyway. We also, with the retinopathy screening, we have our practices that are partaking in our IRIS camera point of care diabetic retinopathy screening program. So that is getting underway. Those practices are being trained. We anticipate that that getting up and running will help move our performance in that end of the metric. Diabetic nephropathy is one that we work on pretty much every year. It's just getting that urine microalbumin at some point. So that remains, if patients are coming in for their routine follow-ups, either having that obtained in the office or sending them a rec to get it done in the lab, checks that box and obviously helps to ensure that the renal function in diabetics is preserved. So that group is largely an effort that's been ongoing. We are trying not to be overly forceful, if you will, and providing additional chase lists. We've already given some. Obviously, the IRIS groups are getting chase lists around their retinopathy screening, so there's a lot of effort ongoing. But we just ask that folks be especially attentive to that because aside from meeting metrics, we know that uncontrolled diabetics are going to be the most at risk, especially if we have a second wave of COVID. The next area is colorectal cancer screening. So this has been a metric we've always done well. Specifically, we're focusing on the Medicaid population because this is the one area where we're sagging a bit. We're currently at the 75th percentile. We've notoriously always been over the 90th. We are now within 100 patients of reaching that plateau in the Excellus program. So this one, it looks like from our data, we should be able to close during our normal course of business with the folks who are remaining on the schedule. But understanding that some folks are not going to be amenable to getting colonoscopies, we just wanted to remind those who have FIT testing within their office to try to push and utilize that as much as possible to close those gaps and make sure people stay on target. The final vein within our pediatrics world is going to really take 2 flavors. So one is in the well care visits, specifically in the age 3 to 6 and well care adolescent. Those are visits that, we had talked about as we were emerging from the pandemic and going back to live visits, trying to prioritize, especially before school. We realize that as school starts, there's going to be an increased need on our pediatricians and family medicine docs to get kids in who are out on isolation from school. So there's only so many hours in the day. But we definitely fell behind just because those were non-essential visits early on, but want to make sure that those kids are getting their immunizations, hitting their developmental screen, and especially in the adolescents, that the mental health factors that are even worse during the pandemic are being addressed. The final two, which are, I'll say, kind of batting cleanup, especially in the Medicaid space, is childhood immunizations and lead screening. Both we are doing extraordinarily well, and I think for a pandemic year, everyone deserves congrats for maintaining those anywhere close to a 90th percentile performance. But it's a few kids that goes a long way, and those are kind of critical benchmarks that could have significant health implications. So much like the diabetics, we want to address those as well. The final piece, which is not really on our radar from a quality metric standpoint, but we think is going to be critically important, is around our flu vaccination program. And so this year, perhaps more than ever, we hope that there's going to be increased interest in flu vaccination. We know that there's going to be less opportunity because employer immunization clinics are going to be canceled and or much smaller than historically, as folks are working remotely or not at all. We also know that many of the community access points, like some of the community pharmacies and perhaps even the health department, are going to have reduced or no access for vaccination walk-in clinics. And we have heard from various folks that the ability to operationalize drop-in flu clinics within your own practices may be impaired. So one of the things that will be useful, and Renee and LJ and I can get together and talk about trying to get some type of survey out to you all. We'd like to hear from you to find out which of your clinics are planning to do flu vaccination this year, whether or not you think there's going to be an impairment of your ability to do so. Would you find valuable if we were to be able to help kind of coordinate some centralized flu vaccination access sites? And do you have enough access to flu vaccine for vaccinating your population if you do plan on having clinics? So those will be kind of important pieces for us to weed out as we kind of look to try to get this stuff very quickly. As unreasonable as it sounds, we probably have to get this really launched within the next couple of weeks, because there's both an increased effort to try to avoid a twin pandemic between flu and COVID-19 potentially rearing its head in the fall. But also we know as it gets colder and potentially we get into a second wave, getting folks into any site to get vaccinations is going to potentially become more difficult. So we want to use this time where outdoor flu tents are possible, and we can ease people's minds that coming into a mass flu vaccination clinic is safe and going to be okay for them and their family. So we will push that questionnaire out to you guys. Please, please, please let us know because we need to really kind of get a sense of how large a population, where are the spots in the network where we need some assistance, cold spots as far as getting vaccine there, so we can start pushing our resources there very quickly. I think that's really I realize that's a really tornadic view of quality metrics, but I think the moral of the story is, in any given year, we would be pushing very hard and really checking individual boxes. We got to get this last patient, we got to get that last patient. We realize that this is a unique year, that you guys are being pulled 1,000 different ways. We want to make sure we're addressing the health of the population, but in something like flu clinic, even though that's not something that's going to check a box for a value-based contract necessarily, it's critically important to the overall health of our population. And so we're going to emphasize those type of activities over some of the more normal things that we'd be pushing attention to. So I don't know if any of the leadership team here has anything they want to add or points they want to bring up. Otherwise, I'm happy to answer any questions if there are any.
If anyone has any questions, you can pipe up, you can throw them in the chat. LJ Shipley, our pediatric medical director, is on the call as well. LJ, I don't know if you have anything you want to add on about pediatric quality measures for 2020. although Chad stole your thunder really effectively, but you know.
He did such an effective stealing of the thunder. I'm sort of left speechless, which is odd. No, I'm being facetious. I think that Chad really highlighted, you know, the quality metrics in peds are bread and butter, pediatrics and what we do. And Chad gave the appropriate shout out to all of the practices for their amazing work in keeping the immunization rates up and lead screening rates up. But I guess I would just say, depending on where you practice and what your school district is doing, there's more or less of a push right now from parents and from the schools to get kids in for some of the well care visits that normally are a full court press at this time of year. And I would just encourage folks to, you know, keep working their list, keep looking for the kids who have fallen behind during the pandemic to try to get as many of them in, you know, as you can. And in saying that, I just really think the only thing I should say is thank you, because I hear that many of you are doing well care visits on the weekend, on Saturdays. Some people have been doing them on Sundays. People have been adding evening hours. So I think anything we can do to support your efforts in doing the good work you do is what we want to do. So thank you, and thank you to all your providers and your staff.
Thanks, LJ. Any questions for Chad or LJ around 2020 quality measure performance? Elizabeth Sharp, our Director of Performance Optimization, is also on the call, available for questions. Anything? Bueller? No? Okay. So we will move on to Willie, who is going to walk us through the recent upgrade to Arcadia. So Willie, take it away, take over the screen.
Let's see. Where are we? There we go.
Perfect.
Okay.
Well, yep, we can see your screen.
Okay. So just want to take a few minutes and talk about the recent upgrade to Arcadia and a few of the features that came along with it. Initially, you know, we upgraded within the past month, and during that upgrade and validation process, we had to stop the EMRs from loading the data into Arcadia. So that's all picked back up, and we're at current for all the data that's in Arcadia, so you can be confident in that. A few of the things that have changed is that when you log in, you'll notice that the username has to be in all lowercase. Arcadia changed over to a different third-party software to regulate access, so they need all lowercase. So if you have anybody in the practice that's having an issue, check logging in, check that first. Then a couple of things I want to point out. The biggest change within Arcadia is the look and feel. So you'll see that it's a little darker, it's a little more compact. I like it because you don't have to swing the mouse back and forth between, you know, various parts of the screen. It's all right there. But for me, the best change is these breadcrumbs on top. These will change and update based on the filters you pick on the left-hand side. And my favorite is this period breadcrumb. So that's always going to show you what data you're looking at that time. Heads up that, you know, as I've gone through the different menus, that has changed. So if I'm looking at the year 2020 and I press a few menus, just verify that hasn't changed. Sometimes it'll change back to trailing year. So a little gotcha there. Other than that, everything is the same on this front screen. You notice when you pick a measure, it doesn't highlight as much as it did last year or last version. I'm not sure if you can see it on my screen, but it's a little lighter color there, but it's underlined. So not too many changes there. The one bigger change is within the patient record. So they've tried to make it a little bit more compact there as well. They've combined a lot of patient cards. medications, you got conditions, risks, basis, and problem list on the same card. You've got the measure, condition, and preventive on the same card, so it's easier to navigate. But the one big plus in this space is that if you remember in the previous versions, they had a similar type of view, but it really didn't have anything to do with the measures that you saw on the front end. And then with the upgrade, these actually are perfect right on to what the patient is adherent to or not adherent to, if they satisfy the gap or not. So that's a quick and easy way to look at a patient and see which gaps they have or which ones they've satisfied. Let's see. And the other addition here is that when you first log into Arcadia, you're going to see this, what they call a widget on top. And before you had to, if you wanted to look at a measure definition, you either had to go through Arcadia and make numerous clicks down, and by the time you got down to the various definitions, okay, which one was it? We had a cheat sheet. And so me and Kevin Kelly created a measure definition page. And instead of going to the AHP network site, you can just click on it from here, and it'll bring you right to the AHP site. And you'll notice on top here that it'll open a new tab. So you won't lose anything that you were looking at on Arcadia. You'll see the new tab, and you can go back and forth. The one thing that has also changed along with the Arcadia upgrade is the inclusion criteria that we're using. So in the past, we used the inclusion criteria, started with all the patients who had a visit within the measurement period. So if you're looking at 2020 as a year, we started with patients who had a visit that measurement period. So what we're doing is stepping back a bit, and we're including patients who are active, all the patients who are active within your EMR. So the reasoning behind that is, if you're concentrating on the patients that always come in for a sick visit or for their physicals, great. But the ones that aren't coming in, who don't usually show up to the doctor's office, don't come in for physicals, we were missing those patients. On a pop health perspective, we wanted to include everybody. And so this is a great chance to maybe go through your EMRs and look at your active patients and kind of clean up, inactivate them if they're no longer in the practice, to clean up your metrics a little bit. So the two big measurements that you're going to see a change on with that criteria is the screening measures. So breast cancer screening and the colorectal cancer screening, because they really don't pare down the qualification too much. So you're looking at all active patients within your EMR who are 52 to 74, in this case, breast cancer screening if they're female. But there's some other measures like diabetic eye. They need to have 2 outpatient visits with a diabetic diagnosis. So within most of these other measures, there's some kind of time frame. So you shouldn't see that big a swing with the other measures. And the only other thing I wanted to bring up is that if you click on one of the measures, you're going to see the exclusion criteria, the inclusion criteria, and all the different information. But you're also going to see a known issues section. So if you're within a measure, if you click on that known issues section, it'll bring up the known issues for that measure. So that's a quick look. But if you wanted to see all the issues that are out there, you just want to click the clear filters, and it's going to show you all the issues that exist. Either the different measures that they go towards, if it's a specific EMR that we have an issue with, or if the issue is open or closed.
Excuse me, Willie. I think your
Willie?
screen might be frozen.
Uh-oh. With that storm, we've had a couple issues here. where is it frozen on?
Way
The
back
front
at the
page.
beginning.
This one?
We can't see your cursor at all. It's just on the Arcadia screenshot.
So where you see the widget on top, the quality measure definition?
Yeah, it's on the
Oh,
Aqua IPP standard page.
All right. Something happened with the network.
Your video looks fine. We can see you're moving around. It's just your screen share is locked up. Maybe stop screen sharing and start over.
All right, let's see.
Now you're cooking.
Now I'm cooking? All right.
Yep.
So let's see. So last thing you saw was me clicking on the widget?
No. We saw you on the IPP Aqua screen.
Okay.
It was before you looked at the patient chart.
Oh, really? All right. So, yeah, I can't get back to that page. So the things I'm talking about here, we have in the documentation. We'll send that out. It highlights all the features I went over. So see how far we have to go back. So the widget on top of the page will bring you to the AHP measures page. And then if you click on, hopefully you're still seeing this. So if you click on any one of the measures, you're going to see the qualification and satisfying the measure, the numerator, denominator, and then within each page you'll see a known issues. And when you click on that, it's going to bring up the known issues for that measure on our known issues page. So that's an easy way to see if there's anything going on with that measure within Arcadia. And to see all the other issues that are out there, you just click the clear filters. And then you see all the issues along with what measure it affects, what EMR it affects, if it's specific to an EMR, and if that issue is open or closed. If you see, so that's basically the issue, things that have changed. If you see any data issues within the EMR versus Arcadia, send me an email. I'll investigate for you. That's what I do. And so our hope is to make sure that, if you see a data issue now, just let me know now. Don't wait till the end of the year. Let's start cleaning those up as soon as we can. So, you have any questions? Let me stop share. There we go.
Anyone have any questions for Willie? Anything in the chat, Kevin, for Willie?
Nothing in the chat.
All right. Well, thank you, Willie. I appreciate that. Paying attention to Arcadia and our performance to quality measures is what helps us, one of the many ways that you all contribute to our success that results in gain sharing and the financial incentives that come from our value-based contract. So what I want to talk to you about now is that success that we did achieve for 2019 and talk about gain sharing. So let me just bring up my screen. Okay, so 2019 gain sharing. So I know we're in 2020, but we just paid out what we earned for our performance in calendar year 2019. So as we have talked about many times in our practice managers meetings, how these gain sharing contracts work is they sit on top of your existing fee for service. We sit across from the desk, the negotiating table with the payer, and we set a budget and quality goals for that attributed population. And the attributed population are the people covered under that particular health plan package, commercial, Medicaid, Medicare, MVP, or Excelis, and that they are patients of yours. So that what brings them into the budget, what makes them attributed, is that they're covered by that plan and they see your physician as a PCP. Under these, we earn upfront clinical integration payments. That's that $1 PMPM that practices receive on a quarterly basis. And when at the end of the year we've met the budget, or we've performed under the budget and we've met our quality goals, then we earn the difference between what was budgeted and what we actually spent for that population. And then that is what is shared with the network. So how did we do in 2019 in this effort? Is we did earn gain sharing, and we earned it under these value-based contracts: Excelis Commercial, MVP Commercial, and the Highland Hospital Health Plan, one of our self-insured employer plans that we're contracted with, excuse me, for which you are all Tier 1 providers, excuse me. And the gain sharing that we earned is then reviewed by our finance committee and then the board of managers, which decides on how we're going to distribute it. Some, of course, is retained by AHP to cover our operating expenses. Some is retained and put into the form of premium to the AHP insurance company. So we've talked about the AHP insurance company before. That is really the mechanism by which we help ourselves manage our risk. As I talked about on the previous slide, when I talked about it in terms of when we beat the budget, sometimes we don't beat the budget. Sometimes we go over the budget, and depending on the contract, we may owe that payer some of that amount that we went over. And it's through the AHP insurance company that we're able to insure ourselves against that loss. So some of what we earn in gain sharing does go into the AHP insurance company as reserves to help us cover those losses. But what's left out of after we've put some into the insurance company, we've managed our own operations. What is remaining is paid out 60% to PCPs, 24% to specialists, 15% to hospitals, and 1% to our non-equity participants, like our physical therapy practices or optometrists and things like that. And I'll talk about that in detail in a second. But we'll talk specifically about what your PCPs how it is they earn. And everyone should have received their payments last week electronically. And we did send you an email to explain what that payment was and include the check detail on that. So all PCPs earned a base amount. They earned an amount based on their number of attributed lives and an amount based on their quality performance. So the base is meant to equally reward all PCPs across the network that participate in all contracts. And that amount of that base for 2019 was $2,100 per provider. So no matter what else, no matter how many patients you have on panel or how you perform on quality, every PCP that participates in all AHP contracts earned a $2,100. Then for lives, we based on what we see in Arcadia of your active lives on panel, every provider earns $3.95 per member. So that's based on all active patients. It's not based on just your Excelis commercial or your Highland Hospital Health Plan, all of your active patients. We recognize that all of the efforts that you do apply to every life on your panel, and we are a population health organization, and we want to support you in helping deliver great outcomes for all of your patients, not just those that are covered under our value-based contracts. So for that reason, we pay out this element of the gain sharing payment based on all of your active lives on panel. And then finally, quality. And the quality component that's included in gain sharing is paid on the same basis as what it was paid for that quality incentive that providers received in late March, early April. So for quality, providers received $6,000 if they were on the gold level, $5,000 if they were in silver, and $1,000 if they were in bronze. If there are any questions, please pop up because I'm in full screen mode and I'm not seeing the chat. Okay. If not, I'll move on to what our specialists will be earning for their 2019 gain sharing. And every specialist in the network will earn, every specialist physician will earn $1,220 base amount. Our specialist physicians, is there a question?
They were on.
If you don't have a question, please mute your phone. So our specialists do earn, specialist physicians do earn gain sharing. They do participate in our contracts and do contribute to our success. But we don't really have quality measures that specialist physicians are being held accountable to at this point. So the only amount they're really eligible for is a base amount. Non-equity facilities. So these are our physical therapy practices and our substance abuse treatment facilities are earning $1,000. And non-equity participants, so these are individual providers like optometrists, nurse midwives, they're earning $700 per person for gain sharing. And the timeline for that was that PCPs were paid. Kevin, can you please mute whoever keeps popping up there, please? Thank you. Our PCPs are paid were paid the week of August 10th. Again, those went out as electronic payments for those of you that shared your banking information with us. A couple of you have not and received a paper check, but the vast majority of you would have received an electronic payment. And then specialists and non-equity, I threw in here mid-September, but actually our CFO, Jim Wright, and I are going to be talking about that probably later today, about the exact timing of when we'll be getting those specialists and non-equity checks. But I would bet we're not planning on it being much later than mid-September. Okay. Any questions for me on our plans for gain sharing? No? Okay. Then I will move on to clinical integration and APPs. So as we talked about at an earlier meeting, we created a class of participation for nurse practitioners and physician assistants who deliver primary care and are employed by an AHP participating practice. And our reason for doing this were many. I mean, we just felt essentially, bottom line, it was important to engage these providers in AHP. They do deliver primary care. We are accountable for their performance to both cost and quality for their attributed population under some of our value-based contracts. So it's important that we include them in the network and that they feel more engaged. And that participation criteria for bringing those folks in, they have to be primary care, nurse practitioners and physician assistants. They have to be certified in a primary care specialty area. They have to be employed by an AHP primary care practice, and they have to have attribution. And what we were asking for practices who were enrolling these providers was a $300 per provider participation fee. And that was one time. That's not something that would be collected annually. That would be a one-time fee. We, and obviously I think the benefits to practices are clear: better engagement, clinical integration dollars, and gain sharing. But specifically what I wanted to talk about was that clinical integration piece, because when we sent practices their most recent clinical integration payment, we wanted to encourage the enrollment of APPs. So what those check detail sheets included was information about the provider in the office. So this example is a one physician provider office. There's only one physician in the office. And this was the amount of that practice's clinical integration check for that quarter. And then what we included, on the bottom of that was if they enrolled their APPs, what the additional clinical integration payment they would have received had they enrolled them. So for this physician, if this practice had enrolled these 5 APPs, that check would have included an additional $3,200. And what we're telling practices who have APPs that have attribution, that you're missing out on this, all you need to do is send us the word, I want to enroll these APPs, and we will net out that $300 participation fee from the clinical integration payment. So if this sounds like your practice, and if you're not sure, you reach out to me and we can discuss this further. All you need to do is say, yeah, I want to enroll my APPs. We will go through that process. In this instance, using this example, we would net out the $300 per provider here, and we would say, yep, they're enrolled. You paid the registration fee. Pay you the balance. That's $1,700 remaining on those APPs clinical integration. And then in the future, what this practice, for example, could expect once they've enrolled these APPs, with those participation fees already netted out, this practice would be getting $4,700 for their physician attribution and around $3,200 for their APP attribution. So there's a real benefit to doing this. It's easy to do. You don't need to write us a check. We're going to net out those registration fees from clinical integration. And again, if you think that what I'm talking about describes you, and I did send you an email inviting you to take part in this process. But if you need that dug up again, we can certainly talk about that. Reach out to me, because this is, you're missing out. Practices with APPs that have attribution are missing out on these dollars, and we think it's well worth your while to just take the step of letting us know that you'd like to enroll your APPs. With that, I will take a break and a breath and see if anyone has any questions.
Nothing in the chat, Renee.
Okay. We do have someone who says they can't hear. Hopefully they can hear now. Okay. Okay. If we don't have any questions, then I will move on to Erica Dobson is our Director of Pharmacy, and she would like to speak with the group about pharmacy visits. So Erica, are you on?
Yeah, I'm here.
Hey, how are you?
Good. How's everyone today? Hope well. So I just wanted to take a few minutes. We're really whipping through the agenda here to talk about our pharmacy visits for 2020. Many of you may remember in 2019, our pharmacy team came out to the practices and talked to the providers about our AHP pharmacy initiatives, which are cost savings initiatives around reducing wasteful prescribing for drugs that are more expensive, that have alternatives that are equally effective and safe but less expensive in our value-based contracts. And we like to do this because it helps us, one, learn more about our practices and our providers, and to share this information back into the practice, since it can be difficult with us playing a centralized role. So we have reached out to you. Jen Horton is our administrative assistant that's assisting us with trying to schedule some of these visits. And some of you, it hasn't been a very good time, to do the visits with all that's going on in the community and with the pandemic currently. And we certainly understand and appreciate that. But we just wanted to let you know, as time goes on, we will reach out again to see if it is a better time for us to meet with the practices. We are open to doing a virtual meeting similar to what we're doing today at a time that's most convenient for the prescribers in the practice. And a lot of times what we do is kind of just take 10-15 minutes at a regularly scheduled meeting. So we just wanted to make sure that people were considering that, and then to be on the lookout for Jen's future email. And also if you have any questions.
Any questions for Erica? The work that Erica and her team do are such a huge part of our ability to earn gain sharing. The PCPs, you do such great work managing quality, but also it's your prescribing patterns and those are specialists too, of course. But and what Erica does is help identify where those opportunities, where some changes in prescribing behaviors can save us money on our budgets, and all of that translates into those financial incentives that turn into gain sharing. So we hope that if some availability crops up for you, that you'd be willing to meet with Erica and her team and have your providers learn more about what they can do to help earn additional incentives. All set, Erica? Thank you so much. Okay.
Thank you.
If there's no questions for Erica, I will move on to talking about information blocking and the 21st Century Cures Act. So this is legislation, the operational aspects of which are likely to start taking place on November 2nd. So this is something that I thought it was important to share with the group and get some feedback from you on. So information blocking, what is that? What am I talking about here? Well, it's a practice that, except as required by law, interferes with a patient's access exchange, or use of their own personal electronic health information. And what this piece of legislation does is it really just legislates how healthcare providers need to share information electronically with patients and each other, and to limit patients' barriers to their own data, and not just the ability to get to it, but to improve their ability to get to it in a timely way. So information blocking, and sorry, this is a new presentation for me, so I'm kind of messing around in here. But when we talk about what kind of information we're talking about, as it relates to that November 2nd date, we're talking progress notes, history and physical, consult note, procedure notes, all of these, according to this legislation, those cohorts of electronic health information have to be shared immediately, have to be made available immediately to patients electronically, with some exceptions. And I'll back up to the exceptions. So if something is needed, if you need to block the information in order to protect an individual's privacy, if you need to block the information to prevent harm to the patient, such as life or physical safety. Like one good example that I heard in a presentation was Huntington's disease results, that those have there's clinical evidence that folks who get their results released to them are at, and are positive for Huntington's, have a high suicide risk. So this is an example of a classification of patient data that a provider might want to hold and not just release without having a chance to talk to the patient and counsel the patient. So that's an example of information blocking that this legislation would say that would be okay to do. So with those, there are some exceptions, and I'm going to give everyone on this call access to the full information where I know it to be about this legislation and the details of it. So what this law is saying is on November 2nd, providers have to make available as quickly as possible, as long as for anything that doesn't meet that list of exceptions, progress note, history and physical, consult note, procedure note, pathology, lab and imaging report narratives, and the discharge summary note. And that is, and that's called the USCDI data set, which stands for United States Core Data for Interoperability. And then May 2nd in 2022, the legislation expands the kind of data that must be made available electronically to patients as soon as possible. And that's the EHI data set, which is electronic health information. All electronic health information is defined under HIPAA. So that's going to be just about everything except for psychotherapy notes. So starting on November 2nd, this has an impact at URMC and MyChart for your patients. So currently, when your patients have a lab or an x-ray, their results are released to MyChart within 24 hours. Within 7 days, they receive results for complex imaging like MRI and PET scan, pathology, and sensitive labs. And sensitive labs are defined as STD, drug screens, pregnancy tests. And then there's also some age-related, for adolescents, STD testing for adolescents. So generally, those are a manual release or a delayed release. So that's current state. So currently, labs and x-rays are going out to patients from MyChart 24 hours, complex imaging 7 days, manual release for HIV results, adolescent STDs, Huntington's, and we talked about why, and genetic testing, and then open notes. So the actual progress note for you of our employed providers are generating for patients are available for ambulatory only. After November 2nd, everything on that list above will be released to MyChart almost immediately, and the open notes aspect will be available not only for ambulatory, but for inpatient. So all of that will be coming out after November 2nd, pushed out to MyChart, which means patients are getting results about things that your providers have ordered and seeing it perhaps in advance of your provider seeing it. And, you know, that has operational implications, I imagine, for your practices. If patients are seeing lab results that they don't understand, they're picking up the phone and they're calling your offices, and you're unprepared because your provider hasn't even gotten a chance to look at it yet. So we wanted to make you aware of all of this happening after November 2nd. Now, this is just the first drop of this information, at least as it relates to AHP. The medical center is implementing a really robust communications plan with providers to make them aware of all of these things and what the implications are. But we wanted to make sure that you knew about it as well. If there's anything I could say to mitigate your alarm that, oh my God, all my patients are going to get their labs immediately and my doctors aren't going to get it and my phone's going to be ringing off the hook, I tell you this. As far as it relates to MyChart, only 50% of patients receiving services at URMC have MyChart, have activated MyChart. So of all the volume of patients being seen at URMC, only 50% of them use the MyChart portal. Of those 50% of patients, of all of their results that are released to MyChart, the read rate of results is 10%. 90% are going unlooked at by patients. Only 10% are even looked at. So just to, you know, make you aware as it relates to that volume, if you have concerns, it isn't everyone that's on MyChart, and it certainly isn't everyone on MyChart looking at everything that's made available. So hopefully that makes you feel a little bit better. So as far as the considerations for practices, there are considerations for you because you're going to be held accountable to that same standard for your patient portals, and that when your provider is seeing the patient, the expectation is going to be that after November 2nd, that their progress note is going to be available to the patient on the portal if they are registered for the portal. You want to be clear here. This legislation doesn't obligate you that if your patient has not signed up for the portal and isn't interested in your portal, that you have to mail them this stuff. That's not the case at all. This is meant to solely legislate how you share information with patients electronically. So what I'm concerned about, because this is very new to me, is just to ask the group, has your EMR vendor been in touch about their plan for compliance? Because the law isn't just holding providers accountable for it, they're holding HIT certified EMR vendors accountable for this compliance. So I'm curious to know if the group, first of all, you know, you want to throw it in the chat or you want to pipe up and talk about it. Were you aware of this legislation? Has your EMR vendor been in touch with you? Is there any consciousness of this looming accountability? And I'll stop talking and ask folks to respond. Okay, we have one comment in the chat that someone wasn't aware that of this legislation.
Janae, can I add?
Yes,
it's LJ. I know that at least from Golisano Children's, and they were hoping to be able to come to our next PCP advisory committee meeting for PEDS and be able to review what the implications are and what their plan is with the primary care providers, to be able to have some dialogue about that prior to this deadline.
Okay, thank you for mentioning that. Absolutely, Golisano has plans to really, because when you think about the implications of this information for adults, but then, you know, think about it in the term of the pediatric population and those, you know, the role of a guardian or a proxy, it might be complicated for practices. So many thanks to Golisano for their leadership that's forthcoming on this. Thanks, LJ, for bringing it up.
Sure.
So looking through the chat, we have a lot of folks who weren't aware. We have a PEDS question right in there. How will this work for patients 12 to 18 years of age? And I think, you know, we're going to be getting that guidance from the process that LJ just described. Okay. So I think that folks ought to be reaching out to their EMR vendor, because I'm hearing like no consciousness of this really in this audience. So I think it's important for you to reach out to your EMR vendor on this. Our role at AHP will certainly be to keep you aware and plugged in to all of the work being done at URMC, how the data that URMC is releasing to your patients over MyChart, you know, what that timeline is, any operational implications for practices we'll be keeping you aware of. LJ referenced what the process will be to help pediatric practices in particular cope. But I do urge everyone to reach out to their EMR vendor. And if you're willing, share back with us what it is that you're hearing. I think that would be really helpful. I'm also going to reach out to the Medical Society and ask if they have any plans about supporting practices through this. I'd be curious to know, because this is a big deal, and I can see it having some major operational implications for practices. Okay. Any questions or other comments from anyone on the AHP team or the audience about this issue? Otherwise, there'll just be plenty more to come. We'll let you know, Toby, if the AAP has guidelines for this. I bet you they will. Okay. All right. If not, I will just mention to folks a couple of reminders, the one that I have to make every time. Please remember to tell your patients that you are in AHP, and make sure that you're doing your best to keep your patients in network so they can benefit from our better care coordination and better communication. Remind folks that this is where all of our emails of how to get a hold of everyone at AHP, or your most common folks that you're getting a hold of. We record these sessions, so I do want to let you know that I will be throwing this up on YouTube later today. It's been difficult to put these up on our website. We have some limitations to the size of these recordings that we can put on our website. YouTube has no such limitations, and I'm also able to edit our recordings so you don't have 10 minutes before the meeting of Kevin's and my patter about our weekend included in that recording. So we'll get that URL out to you when that is up on YouTube. So if you want to share this presentation with anyone in your office. Also want to remind folks that if you're eligible for a PPE distribution, pickup for your allocation is tomorrow, 9 a.m. If you haven't completed the survey, you have literally 1 minute left before the survey closes to request your allocation. So better run over to do that now. And that's all of the content that we had for you this morning. Brought it in right at an hour, but please, I have more time if we want to open this up for discussion, any questions, any issues we didn't cover that we can help you with. Okay, well, I don't hear anyone popping up, so I thank you for your time this morning. We will plan on having another one of these sessions in December. We'll keep the information flowing as always with our weekly on Wednesday COVID calls. Anything more that we learn about the Cures Act and how it in fact impacts you with regard to information blocking, we will be getting out to you. And just encourage you, if you have anything that you need that you think AHP can be helpful to you, please reach out to me or to Kevin. And we're looking forward to hearing from you. So have a good rest of the day. Thank you for participating. We'll see you again soon.
Take care, everybody.
Bye-bye.
Thank you all. Take care.